and welcome to everyone joining us live here on GBMC's Greater Living. I'm Mary Beth Marsden, and my friend and colleague Don Scott is out in the field today, so you're going to have to stick around to see where he is and who he's talking to. So today we're going to be talking about these beautiful organs on the sides of our heads, right, that sometimes go unnoticed and taken for granted. But first we want to talk about a big, beautiful name that has recently been unveiled. And joining us now is Dr. Brian Kaplan, who is the chairman of the Department of Otolaryngology at the Presbyterian Board of Governors Cochlear Implant Center of Excellence at GBMC. I want everyone to practice that. Say it 3 times. And
Well
it'll
done.
become natural. Thank you.
That's not easy. One breath.
Yeah, thanks. So we want to focus on the name. It's a long name, but it's an important name because it's making an amazing difference at the center. Can you just tell us all about that?
Sure. So the Presbyterian Board was actually part of the foundation of how GBMC was formed back in 1965. 2 organizations came together, the Presbyterian Board and the Charity Board, and formed GBMC Hospital. So it was the eye, ear, and throat hospital that then merged with the women's charity group to form GBMC. So GBMC has a foundation of otolaryngology, which is the fancy name for ear, nose, and throat excellence.
I read somewhere, too, that that's one of the oldest specialties in the United States. Is that true?
And eyes used to be included back a long time ago. It was ears, eyes, nose, and throat. And so the Presbyterian Board has been one of really the best philanthropic groups to the hospital throughout the decades of the hospital's existence. Has really been a center point of many of the very best programs that were created at the hospital. So we were extremely appreciative and thankful when they were amenable and approached us about potentially supporting what was already a really landmark center for the hospital to bring it to the next level. A
landmark center, but also probably busting at the seams, right? I mean, you had a lot of people who needed your help, and you needed help giving them that help.
It's absolutely right.
Yeah.
We have doubled in the past 2 years. We could probably more than double again in the next 2 years. But you reach the glass ceiling bottleneck of how to take care of all these patients, not only just getting folks into the operating room evaluated and operated upon, but what happens for the aftercare for a cochlear implant, which we can talk more about later, really is very time, labor, and financially intensive.
We are
to support that.
We do want to talk about all the specifics from the very basics on up, but you have sort of this global view of what's happening, and you said you had so many people who needed your services. What is happening? Are people just becoming more aware? Are really people just struggling with their hearing more and more? Is it getting worse for people in this world, in this loud, noisy world that we live in?
So, look, everything starts with prevention, no matter where you are and what part of the world, right? Protecting the hearing you've got, protecting the hearing you were born with is paramount. And we know the kids with the earbuds, the loud headphones, work exposure, all leads to hearing loss. But even having said that, the rate of hearing loss is actually increasing worldwide. The latest numbers that came out this year from the World Health Organization were 460 million people living with disabling hearing loss right now in the world. That's going to be about 900 million people in 2050. Of the people who are eligible today for a cochlear implant, even in the United States, only 5% of them so far have a cochlear implant. So we haven't scratched the surface on 95% of the patients who could really use this technology for a really drastic improvement in their quality of life.
I'm probably going to ask you a question that would take an hour to answer, but can you really quickly say, why is this happening? Or what are some of the biggest theories?
Well, some of the biggest theories are the environmental exposure, like we talked about. Other parts of the world, there's genetic predisposition, sometimes nutritional factors. Getting older is a huge portion of this problem. We all start losing hearing from the moment we're born. It gets worse the older you get. As the population continues to age, we're going to have larger percentages of patients with disabling hearing loss.
And for you, I would imagine that's unacceptable. Right?
It's totally unacceptable, and it should be for everybody in the audience.
For everybody, right?
Not just for me.
Because we forget. I mean, some of us say, oh, I'm just getting old, my back hurts, I'm losing my hearing, whatever it is. But when you lose your hearing, as many people know, it becomes this most isolating situation.
Well, not only is it isolating, but if you think about other health problems as you get older, right? If you say that you're losing your vision, you wouldn't say, oh, it's just part of getting older. You would go and you'd immediately put on glasses to try to see a little bit better. If your blood sugars were too high, you'd immediately get that fixed so you don't go blind or run the risk of losing a limb. If your blood pressure is too high, you'd get that fixed so you don't have a stroke or have a heart attack. When it comes to hearing, people say it's just a normal part of getting older. You don't have to deal with it. That was the case until a few years ago, and we've started accumulating more and more good evidence now about the importance of hearing loss and how it ties in to some very serious health concerns.
Such as?
Dementia is really number one. It's pretty shocking of the rates of dementia and the link with hearing loss. A mild hearing loss doubles your chance of having dementia. A moderate hearing loss, you have 3 times the chance of dementia, and a severe hearing loss, a 5 times chance of dementia. Much higher rates of falls, social isolation, depression, hospital admissions, all things linked with hearing loss. And the early evidence now is pointing towards the importance of treating the hearing loss early and potentially delaying or preventing some of those causes of dementia.
So now I want to go back to the basics, and I think a lot of people are unaware of what is a dangerous level of noise for their ears, and it's all measured in decibels.
Correct.
Right?
Absolutely.
And I had mentioned to you when we were talking in the hallway that I now wear earplugs at live concerts. And my husband was at a concert last weekend at Pier 6, which is an outdoor venue, so you would think maybe the noise would just kind of go off. But they measured the decibels at 118 decibels. And I thought, what does that mean exactly? So conversation that we're having right now would be, it might even be louder than 60, right? Because we're kind of projecting, but 60 decibels is a normal conversation. What is the limit where you're getting into dangerous territory?
So the limit is a combination of how loud is the sound you're exposed to and how long are you exposed for it. OSHA here in the United States has very strict guidelines in a workplace environment of at a given decibel level how long you can be exposed. Those regulations start around 90 decibels and move up, and they go down even by just a couple of hours. So you can't have prolonged exposure without proper hearing protection at those levels because you will cause permanent loss of hearing at that point. So protecting your hearing at the concerts, using power tools, lawnmowers, all those things are really crucial. You're born with about 16,000 of those little hair cells in your inner ear that are the nerve endings. You can't make new ones, and you start losing them from the time you're born. So every time you went to a concert and your ears were ringing a little bit when you came out, you injured some and you killed some. And you accelerated the loss, and there's certainly genetic aspects and normal aging process, but that noise exposure is probably the single biggest risk factor that you could do something about.
So if you walk past a construction site and you hear drilling one time, but if you do it every single day, multiple times a day,
Yes,
that's a problem.
That's a problem.
And you mentioned, too, that if anybody has a smartphone, you can have an app that can measure decibels. So if you're concerned about, where you are and how loud it is. And But, so technology is great on one hand, but on the other hand, we're all wearing earbuds. In broadcasting, had to wear an earpiece in my left ear for about 25 years. And when you would plug it into what they would call a mult box or any other kind of place that would provide the audio, you never knew where the volume was at any time. So many times I would be blasted in my ear, and I have lost my high-pitched, well, you said I might have lost more my other ear too, but when you rub your 2 fingers together, I can't hear it on this ear, but when I rub it here, I can hear it very clearly. It's a great way to test your high. See, everyone's doing it now, right?
Come over to GBMC and visit us.
I should. I need to get another hearing test. So anyway, it's very prevalent. We all may be, or many of us may be living with it and not even know it.
Correct.
And there's help, and that's the whole point.
There's absolutely help, and if you just looked out in the general world here, a third of 65-year-olds, half of 75-year-olds, and basically every 90-year-old has significant hearing loss if you test.
All right, so when should we be tested? I mean, when should we start, or how often, or?
So we have that where we are today and where we hope to be. So
okay.
Where we are today, obviously we're looking for things of normal conversation. Can you use a phone? That's actually one of the most telling signs that we can find. If you're struggling with the telephone, if you're struggling with a cell phone, if you're struggling in a meeting environment or at church or in a classroom setting, lecture halls with funny acoustics, if you don't even bother going out to dinner anymore because you say, I sit at the table in the loud restaurant, I can't hear the conversation across the table, I promise you people aren't mumbling. No one's talking faster than they used to. It's the hearing loss is reflecting in that type of way. And that's when it's time to really be addressed. There's usually about a 7-year gap from when people's family knows that you have a hearing loss and you should do something about it to when the patient acknowledges they have a hearing loss. And even when you talk things like cochlear implant, there's a 12-year gap from when a patient becomes a cochlear implant candidate to when they typically end up in our office. So there's a lot of denial that goes into this.
And before I ask you who would be a cochlear implant candidate, I want to talk about just common sense practice for everyday people who, wherever they are in their hearing situation. Do you recommend not putting a phone up to your ear? Do you recommend using the speaker whenever you can?
At normal conversational volumes, it's fine to put the phone up to your ear, and same with earbuds. The idea is you want to be able to hear the world and conversation around you, even if you had an earbud in place and you're at a safe conversational level. You can actually set the volume limits on the phone. So for parents out there with the kids, you can put it up, find what a safe level, and set the parental limit on that to help try to prevent that.
Any grandparents out there? That's what you need to tell your kids to do for their... My mom always has advice for me. I usually ignore it, but that...
Good luck.
that I might actually do.
Yep.
So let's say we go through those years and we haven't been able to hear, and our friends and family say, I always have to repeat myself.
Yep.
Get your hearing checked. That's the first step, obviously. Then, are you looking at choices? Is the choice a hearing aid? Is the choice a cochlear implant? How do you decide who's a candidate for either?
Yep. So once you've diagnosed hearing loss, you have to decide which bucket of hearing loss you're going to put this into. There's really two big classes of hearing loss in the world. One's called conductive hearing loss, and one is nerve hearing loss. The conduction side means something is blocking the sound from getting in. That could be eardrum problems, fluid, hearing bones, infection, wax, any of those things. We can usually do something to fix that surgically. On the nerve side, we can't really fix that surgically. So as the nerve starts to drop down, a hearing aid is the right option for the vast majority of patients. Hearing aids make the sound louder.
Percentage-wise?
90-something% of the nerve damaged patients will benefit from a hearing loss. Hearing aids make the sound louder. They do not make the sound clearer. They rely on your ear being able to hear that sound clearly if we crank the volume up loud enough. At some point, all you get is louder, distorted noise from a hearing aid. That's where a cochlear implant comes in, because a cochlear implant restores the clarity of the sound, not just the volume of the sound.
Why not just skip right to the cochlear implant?
Always try the less invasive measure first, right? A cochlear implant is now a very quick, safe outpatient surgery, but it's still a surgery. So if you can do this without any need for anesthetic and the cost and associated aftercare, try the hearing aid first.
Have we hit sort of a plateau with hearing aids as far as what they're able to do for people?
So it's never really a plateau. It's like a plateau for your iPhone, right? So they get a little better every year, but it isn't usually a massive change compared to the earlier generation. So they get a little smaller and a little faster, and the battery gets a little bit better. They get a little better at filtering out some background noise. But they still are limited by the function of your inner ear and the nerve going to the brain. They can't improve upon that.
We have a comment, I think, that someone would like to make, or a question?
We have a comment. It's from Emily on Facebook. Emily says, Dr. Kaplan is the best. And then she says, is there any advancement in hair cell regeneration within the cochlea?
Thanks, Emily.
That's a great. Emily is not my sister. Thank you, Emily.
Your wife?
Not my wife. So it's a great question. We've been working on hair cell regeneration for about 25 years or 30 years now. For the last 30 years, hair cell regeneration has always been 10 years away. Didn't matter when you asked that question, the answer you got was 10 years from now. We are getting much better, especially in the lab, at being able to regrow hair cells. Sometimes it's actually regrowing the hairs themselves. Sometimes it's tricking the cell next to the hair cell to turn into a new hair cell. There's a lot of research going on about how do we restore that inner ear function. A lot of companies are getting involved. It is not anywhere close to being clinically ready for a patient just to walk into the office to have that done.
Okay. So I think a lot of people, when you touched on it, and I want to go back to it because we're kind of getting to that point where people now, we've gotten to the point where we want to get checked out. We have to figure out what kind of category we fall into with our hearing loss and what would be the next step. But some people still put that off. They think they can live with the hearing loss and it's not worth the effort. So I want to circle back to the findings in the studies, which I'm sure there are many more to come, that say if you don't get your hearing checked and you don't try and work with this problem and make it better, chances are greater that you could live with dementia.
Absolutely.
Or depression. And these are things that really, I think,
Absolutely.
If the hearing doesn't become a red flag for people, when they hear they have a greater chance of dementia, that is the thing that may get them to kind of do something about it.
So the thing that helped us change this conversation the most was a big paper last year, came out of the Lancet Medical Journal, which is one of the premier medical journals in the world, that looked at all things related to dementia and all causes of dementia. And one of the findings in the paper was that the single biggest modifiable risk factor that came to dementia was dealing with middle-age hearing loss. It was the number one thing you could do to try to head off dementia down the road. So we know that keeping you hearing is good for your brain. The same idea as being engaged with your surroundings and going out of the house and doing crossword puzzles and all things that use your brain are good for your brain to keep it young, and that's the same with hearing. You've got to keep the input coming in. When you talk about things like a cochlear implant, one of the single biggest predictors we can have about how well are you going to do with your cochlear implant is how long have you been without hearing. We don't like it if your ear and your brain haven't been hearing. It won't work as well down the road. So when you start having hearing loss, it's important to treat with a hearing aid. When the hearing aid is no longer giving you enough benefit, it's important to then think about implantation.
Is it that your brain just starts to forget how to process what the noise that's coming in?
So there's a couple of different theories about that. We don't have the final answer. Some of it is likely that your brain just says, you're not using this anymore. We're going to use that part of your brain for doing something else. And it repurposes that part of your brain.
So your brain needs the cochlear implant or the hearing aid. I mean, your brain needs to hear.
Hearing is part of healthy aging. And hearing is part of a healthy brain as part of healthy aging.
But what about for people who never could hear?
So if you're born without hearing loss, we know that if we implant you at a young age, and by that we'd like to implant you by 12 months of age, we can have normal speech and language development, normal schooling, normal work experience. The longer that the time goes by, the more of a delay and the lower your ceiling is going to be from a speech and language development. So it isn't that those people can't get any benefit, but they don't get nearly the benefit they can if they're implanted earlier.
So earlier is better.
Earlier is better.
This may seem like an old school question, and maybe it doesn't even apply anymore, but I can remember a time when people who were born without hearing wanted to stay that way.
Yep.
And felt that medical intervention was somehow demeaning who they were.
Yep, and that was obviously a hot button issue about 10 or 20 years ago. There's still obviously discussion that goes on that topic, but it's become much more accepted. And it isn't always that there's a wall set up between the deaf community and the hearing and the cochlear implant. And there's actually now patients at the deaf schools and universities with cochlear implants utilizing both educational streams and doing it very well.
Another question?
Yes, this is from our audience. Using hearing aid cranks the sound higher so sound can be heard. Can this louder sound further impair hearing later?
Great question. So when you program a a hearing aid, and that's done by your audiologist, not by me, because you probably would lose your hearing if I did it. There are limits set on the volume of what will come out of that. So if you go to a loud concert, if you walk by a loud noise, we don't just amplify that loud noise even further and pipe it in, because that would cause damage. So there's a limiting governor agent.
Gone are the days when the hearing aid would go make that really loud noise periodically, or there would be feedback, or
it's almost gone. It's not quite gone. If you still cover a hearing aid, you can get some of that feedback. But for normal everyday use, we typically don't get the feedback problem.
And also, people used to not like the way they would look, but they look much better now. They're smaller.
Invisible. They're invisible almost even if you have my hair, let alone if you have your hair. They've become teeny. Even if somebody's looking at your ear, in most cases, they can't even see you're wearing one.
I want to talk about now the cochlear implant and who is actually a candidate. Is anyone not a candidate?
If you have no nerve connecting your inner ear to your brain, you're not a candidate. Short of that, you are quite likely a candidate. There's still further medical evaluations we have to do. But in general, if you have hearing loss and you've been wearing properly fit and programmed hearing aids and say, I just can't do what I need to do, then you are quite possibly a cochlear implant candidate. And then you come on in, there's a specialized set of hearing tests we have to give you that mimic real world. We put you in background noise and make you listen for sentences. A lot of people don't do so well in those situations, as you can imagine. And we have very strict criteria of who will fit into a candidacy for cochlear implantation.
Some of the most amazing videos I've ever seen are people who, and I'm sure you all have seen them too, children, even babies, and I mean 12 months or toddlers, but who get the cochlear implant for the first time and they hear their parents' voice, or it's the most beautiful. It brings me to tears when I think about it.
It's as close to magic as we get, right? So if you give me 90 minutes, we can do a quick outpatient procedure and have you hearing for the rest of your life. And it's really pretty amazing.
So that would never get old for you to see that. It never gets old. Yeah, just to see that moment. I would want everyone in the whole center to come and just watch that whole moment.
That's why you do it.
Yeah, those are the moments. John, I think you have a question, right?
Yeah, two-part question. First part is, what is cognitive hearing loss, and can anything be done for cognitive hearing loss through hearing aids or other means?
So cognitive hearing loss is how your brain is processing the sound. When you think of hearing, our ears need to pick up the sound to send to your brain needs to process the sound. So how well the brain is doing in that situation really can play a difference.
Are we just talking sound and language? Or
correct.
Okay.
more language than sound.
Okay.
And so putting that together, there's often people who do very well hearing a sound, even at a very soft level, but can't understand speech and the clarity of words. So anything which improves cognitive function, and those are things as simple as blood pressure control and diabetes control and good nutrition and exercise and sleep are all important. Staying engaged with your external surroundings are important. And then maintaining hearing. So we have that input coming in and not having a deficit where you don't hear anything for an extended period of time.
When you get the implant, what's the recovery like, and what's the therapy following like? Or you must have to learn to use it, or learn to figure out what those sounds are that you're now hearing for the first time.
There is, and it matters. Obviously, if you've been hearing your entire life, if you've been wearing hearing aids, it's a much quicker path to hearing well with a cochlear implant. Children have a totally different pathway, a much more intensive pathway to make sure they follow as close as we can to their age-matched peers. For adults, they go home about 2 hours after their surgery. They usually have one quick post-operative check a week later, and then it's all with the speech therapist and with the audiologist working on the programming and then on their therapy. And they come in typically about 4 to 5 times over the next year for those appointments to be fine-tuned. And then they have plenty of homework to do at home. The most important thing they can do is put that cochlear implant on when they wake up in the morning and leave it on until they go to bed at night.
Are there reasons why they wouldn't want it? Sometimes do they want to tune out?
Sometimes they got to this point of hearing loss and they've become socially isolated. They've stopped going to the parties and to the meetings and to the organizational gatherings. And we have to re-engage them because you need to be around people who are talking and speaking and have your brain listening to these sounds all day long.
And so that almost becomes an exercise a little bit in psychology.
Absolutely. And a lot of what we say is expectation management is some of the most important things that we do. We have to set that bar early to let them know what it's going to take to succeed, and we're going to give them the tools to succeed.
We talked about children with hearing loss, and we talked about adults who are getting older. What about someone who's had a traumatic event? Do you see that as well?
We see traumatic events. Even more common than that is actually just sudden hearing loss, which is more common than you'd think. So an otherwise
brought on by what?
Often no idea. Sometimes a viral infection, sometimes autoimmune disease, sometimes trauma or a little vascular insult.
Can a Q-tip do it?
Q-tip can do other things. It won't do that.
Okay, good.
We see that all the time. Yes, we'll take care of you.
All right. So these things can just happen suddenly.
Yep.
And but they're still possibly candidates.
They're possibly. So if someone comes in suddenly, you don't rush down the cochlear implant route. There's often medical management that you have to try to evaluate why did this happen, and then how can we treat them to try to recover that hearing. But if we can't, then we have options, either hearing aid or cochlear implantation.
Did we talk about calcification?
We did not.
Let's do it.
Okay.
Explain to us what that is.
So calcification, when we got back to those 2 buckets of hearing loss we talked about, the first bucket, the conduction problem. Calcification is the growth of new bone in the ear. Usually you have 3 little hearing bones in your inner ear, and the third one is called your stapes. Often there's calcifications around the stapes itself. That's called otosclerosis, where that bone just doesn't wiggle anymore. And that causes that conductive hearing loss, in which case you take out the third one and put in a fake third one.
Do you ever find a lot of people deal with TMJ? This may be off,
Yep.
but it affects your ear and pain around your ear.
Yes, so that's a daily occurrence in the office. Patients come in thinking they have a horrible ear
Right.
infection. Their ear is killing them, and you look in their ear and it's completely normal. And often that's a TMJ where people clench their teeth or grind their teeth and the muscle tension associated with it. But you can often treat that medically.
I'm impressed that they come in for that.
They come in. If it hurts bad enough, they come in.
Yeah, after the Advil won't work, right? So before we have a lot of people to talk with today. This has been great, though. I just want you to know, but we have actually people here, patients of yours and others in the center who have had the cochlear implants, and I can't wait to hear about how their life has changed. But before we let you go, I just want to give you the opportunity once again just to talk about the Presbyterian Board of Governors, the Cochlear Implant Center of Excellence at GBMC, and where you are and where you hope to be in, which we say, 2 years, 5 years?
No, earlier.
All right, a year.
Sure. Let's do 1 to 2 years. We know that we've doubled in 2 years from a surgical side. We think we can come close to doubling that again. The aftercare, all the programming and rehab that goes on is really where the bottleneck has been. So expanding our aftercare so we can increase the number of patients that we're caring for, both in our community and really regionally, because we're now a regional referral center for this problem. And then how do we start leveraging technology for patients who live 3, 4, 5 hours away or don't have access to transportation? how do we leverage technology so they can do some of these things from home? Being involved in groundbreaking research to be able to spread this to both outside audiologists, internal medicine, patients, so they understand the value of the technology and they can find us and we can help them.
All right. So you probably have your mind going all the time, right?
There's no shortage of ideas.
All right. Thank you so much for being with us and talking. Dr. Brian Kaplan.